Hi, I'm Dr. Melanie Thomas and I'm the Clinical Director for Lymphedema Wales. I'm going to present to you today on the Cellulitis Improvement Programme. Let's see now then if we can get this to work. Share screen. So I don't know if you're aware, but actually in Wales, 37,000 bed days are actually occupied by people who've got cellulitis. And that's quite a lot. And lots of these patients actually have a recurrence rate, i.e. they have another cellulitis. Up to 50% will have another episode within their lifetime. And between 10 and 20% will have another episode within 18 months. So we felt we could do something about this and be a little bit proactive. So the primary objective is to offer people who've had a cellulitis some advice about preventing another episode. But also let's do a lot of education to reduce some of these risk factors. So we had 3 8A positions that was funded by Welsh Government, and we started this programme of work right at the beginning of the pandemic, January 2020. But I'm delighted to tell you that what we've done is we work through each individual hospital and we look who's been admitted with cellulitis in the previous 18 months, and then we send them a letter and a leaflet about reducing the risk of cellulitis. And you can see there they've actually sent out 6,000 patients, 6,000 letters have gone out, and it's about a 50% uptake. And you can see we've been to all different hospitals throughout all of Wales. We're just going to North Wales next. So what can I tell you? Now, this is based on data on 1,150 patients who've actually completed the programme of work. The average total amount of cellulitis is 2,739. The majority of it occurs in the lower limbs. The age group, 68% are over 60, and it's slightly more men than women. But when you look at length of stay in hospital, for those 1,150 patients, it's 13,000 bed days that are occupied. Then if you look at the cellulitis causes and risk factors, well, the biggest factor that patients feel they've had a cellulitis is a wound, 34%, but 29% don't know why. But when we went into their past medical history, you can see lots of patients actually had skin problems, dermatitis, eczema, the frailty, so 43% were vulnerable or more. Lots of patients were obese, and the risk factors, you can see there, lymphedema, 45%. So lymphedema is a risk factor. Surprisingly, 59% of the people that they've seen were not known to the lymphedema service. And what did we do? Well, obviously we give advice, skincare, exercise, weight management and compression to stop that lymphedema from occurring. If you've got limbs that are very swollen, you can imagine it's like having 10 different takeaways for that bacteria to thrive on. So that's why we want to get rid of that edema. The other thing to say is prophylactically, 50% of patients should have been on prophylactic antibiotics, i.e. they've had 2 or more episodes in 1 year. They weren't on it, but they are now. What about patient-reported outcome measures? Lymphedema Wales, we're really into PROMs. Surprisingly, there isn't a cellulitis PROM, so we have created one and it's currently going through validation. So what I can tell you about CelluPROM is that the anxiety and fear factor dramatically reduces since those patients have been on the programme. And you can see the areas in the red boxes, those are actually statistically significant. So pain, personal care, home life, hobbies, walking, anxiety and fear. What about the money? Because obviously everybody's interested in benefits these days. So what I can tell you about is of these 1,150 patients, if you cost out how much it actually costed the NHS to having to look after these patients, it comes in about 3.6 million. So you can see oral antibiotics, IV antibiotics, number of nights in hospital, going through ED, the GP, some went through the GP, some went straight to ED. If we estimated 10% of those 1,150 would have another episode, it would cost 428,000. But surprisingly, well, not surprisingly, only 18 patients have gone on to have another episode in the 1 year that they've been part of the programme. So that's really exciting, obviously patient benefits and financial for the NHS. We've also done a little bit of work with the finance delivery unit. And what they have said is that do you know, this screen. So what they have actually said is it's £2,000 per episode every time somebody has a cellulitis. So that would actually equal to be a lot more than the projected 3.6. It would actually be 5.4 million. So we know we're doing something right. So the other thing to say, what about primary care? Yes, cellulitis is occurring in primary care as well. And what we found out through the SAIL database is that actually 2019, it cost 7.8 million for 75,000 contacts, or 75,000 people who were having cellulitis. And interestingly, we've worked with one GP practice and we found out that 12 patients were on repeat flucloxacillin. They shouldn't have been. And other things to say is 104 had 2 episodes in a year, 44 had 3 episodes, and 22 had 4 or more courses of flucloxacillin. So we definitely need to see those patients. And with that graph, you can see the black is actually flucloxacillin. The all Wales is that black line. Then you've got one of the health boards, and then that blue line is that particular GP practice. The other thing to say as well is the more deprivation, the more deprived area, that's where more admissions, more GP contacts are occurring. So that's it from us. Thank you so much for listening to me. I hope I'm within the 8 minutes. If you need anything, please contact me. Thank you.
Bore pob. Hi, I'm Claire Rockcliffe-Fidler. As most of you will be aware, in recent years there have been a number of high-profile media campaigns increasing the public's awareness about mental health difficulty and encouraging people to speak out and seek help. Despite this, mental health and well-being is still rarely spoken about in much other than a strapline, and so people still don't have access to trusted and accurate information and guidance. So this means that many people end up struggling in silence and then present for help when their concerns become significant. It's been estimated that 2 in 5 GP appointments relate to mental health, and GPs have been asking for support with this demand for some time. Aneurin Bevan University Health Board had already started making plans for responding to this need when the COVID pandemic hit, and so this really reinforced the need for urgent assistance. Given that the majority of presentations for mental health concern relate to mild to moderate levels of distress, our health board introduced practitioners who would offer a proportionate and appropriate consultation for this population right at the front door, so to speak, in GP surgeries. We wanted to bring sufficient expertise upstream so that this majority have rapid access to a well-informed, evidence-based approach when they have concerns about their mental health. We drew from models elsewhere in the UK and developed a role for psychological wellbeing practitioners, or PWPs as you'll see them referred to on the slides, that exploited their biopsychosocial assessment and case formulation skills. This work was also done in partnership between our primary care and mental health divisions. Our Band 5 practitioners are non-registrant, experienced mental health practitioners who can see any adult with mild to moderate mental health concerns. They create extra capacity for GPs in that they are located within the surgeries, with appointments ideally being booked directly in with the PWP rather than a GP. They adopt a similar approach to GPs, but offer 45-minute appointments in which they endeavour to understand the nature of the person's concerns, offering psychoeducation to try to assist the person to understand what might be contributing to their difficulties, and then discuss with them what the next steps for them might be. This might include watchful waiting, self-directed learning or self-help, usually to CBT related or cognitive behavioural therapy resources, signposting to community resources and assets, or referral direct to the next step, the primary care mental health support service waiting list. Occasionally referral back up to GPs if there's a discussion required regarding medication, or referral onto specialist services. And unfortunately, our PWPs don't currently have formal links to refer direct to the next step, which would be community mental health support services, but that is work in progress. The early data from our service suggests that they're seeing exactly the population we were aiming to provide a service to. You can see from the graphic on the left that the main primary problems are low mood, worry and stress. That said, only 11% of the people they see are considered to present with what we would describe as a so-called kind of simple presentation. Most often the picture is one of comorbidity, usually with low mood and anxiety, but not exclusively so. As you can see from the graph on the right, our referral rate into our primary care support service is around, sort of totals up to around 20%, and about 7% of people are booked back in with a GP for discussions about, medication and so on and so forth. But most pleasingly, if you can draw your attention to the green bars and below, over 66%, so sort of totaled up 66% of our recommended next steps involve some form of self-help, and 41% signposted to community resources, with the rest being sort of some limited follow-up or watchful waiting, or perhaps even no follow-up being required. The previous outcomes appear more significant when considered alongside the patient feedback that we routinely gather via our patient-related experience measure, or PREM. In particular, I'd like to draw your attention to the following response data. The table on the left demonstrates the very high ratings given for feeling listened to and understood by the PWP, with 84% mostly or definitely understanding how to manage the difficulties they're having at the end of the appointment with the PWP. Significantly, the slide on the right illustrates that 86% of people reported that it was very likely that they would follow the suggestions discussed in the appointment about how to manage their difficulties going forward. Our PREM also has an overall satisfaction rating, and 61% of people rated their experience as 10 out of 10, with 92% of all respondents scoring us 8 out of 10 or above. Now, hearing the voices of the people who use our service has not only helped us to develop it further, but also provided additional feedback suggesting the value of the service. I'd like to share with you some quotes.
It's the first time I've been listened to properly in 10 years. I felt like the practitioner had heard everything and understood what I meant.
I am extremely happy. It encourages a mindset in the patient that someone actually cares about their experience and has a handle on the situation. Your service has provided hope where there wasn't any.
It gave me hope that there were many options available, and it felt good to finally have options other than medication.
It is an extremely valuable service that makes people feel listened to. This has helped both myself and my father. The service will save lives.
And as if that wasn't hope inspiring enough, the early data from our GP informatics system searches has also proved very encouraging indeed. A sample of data from GP surgeries was analysed, specifically looking at whether seeing a PWP has any impact on GP recurrence rates and new prescription of common first-line medication. In this sample, recurrence rates 3 months before seeing a PWP compared to 3 months after indicated a 54% reduction in recurrence of GP appointments. Predictably and reassuringly, we've also observed a dramatic drop in rates of new prescriptions for this population when a PWP is seen, from 56% if seen by a GP only, compared to 7% if seen by a PWP. And if that trend continues, as we would anticipate, we would expect this to further reduce GP recurrence rates. We're aware that this is very early days, and we're looking to extend not only our data sample size, but also the follow-up period. In conclusion, these appropriately experienced practitioners appear to represent a proportionate and effective response to the significant demand for mild to moderate severity mental health concern in GP surgeries, in line with the Welsh Government plan. Our service data suggests that they are offering evidence-based suggestions, psychoeducation, particularly cognitive behavioural therapies, using step care models, and that these approaches are valued by the people that they see. As such, we've received moving and overwhelmingly positive feedback from the people who've used our service. The early indicators are that there is the potential for longer-term reduction of GP appointment recurrence and pathologizing of low-level emotional distress. Statistically robust data is still being sought, but this looks very promising as one way to moving forward together towards a healthier Wales. I hope I say this right. Diolch yn fawr, hwyl fawr. Bye everyone.
Hello, my name is Sophie Kirby. I'm a cancer specialist physiotherapist based in Singleton Hospital, and I'm going to talk to you about a pathway that we put in place for patients with metastatic spinal cord compression to ensure that they receive the equal gold standard care throughout the service. So what is metastatic spinal cord compression, or MSCC? Now, NICE have given a quite wordy description of it. I've put it up there, but essentially what it is when cancer spreads to or near to the spine and compresses on the spinal cord. We know that 5 to 10% of cancer patients will develop MSCC, and we also know that this statistic is going to get even greater with better diagnostics and treatment. It's classed as an oncological emergency, and that's because without efficient and effective treatment, results can be catastrophic, and that means for the patient, paralysis or even death. So classically, treatment from MSCC is radiotherapy, and that's given either in 5 fractions over 5 days, single fraction given in 1 shot in 1 day. It's given in Singleton Hospital for the South West Wales Cancer Centre, which covers a large geographical area. And in that map there, you can see that the geographical area we cover is areas 1 and 6 in the orange and green areas, covering 2 health boards, that's Hywel and Swansea Bay. So what was the problem? Well, initially the problem was that all patients within that area were having to be admitted to Ward 12 Singleton for radiotherapy. Then in 2019, a trial got produced called the SCORAD trial, which looked at whether 5 fractions of radiotherapy versus 1 fraction of radiotherapy was beneficial and what functional outcomes were best. And it actually proved that both of them produced the same functional outcomes. With then COVID coming in 2020, there was a big push for a single fraction of treatment. That meant that patients would only need to come to Singleton for 1 lot of radiotherapy and wouldn't necessarily need to be admitted to the ward. Now, we know that these patients need specialist physiotherapy intervention. It's stated in the NICE guidelines. But what was happening with the new single fraction treatment is these patients were coming in as outpatients and weren't receiving this specialist input, which resulted then in lengthy hospital stays and inequalities of the service, because Swansea Bay patients were getting specialist input, whereas Hywel patients weren't getting that input. In 2019, before the SCORAD trial came in, the length of stay for MSCC patients was 13 days in Singleton. That's a huge amount of time for a patient to be stuck in hospital. So what did we do? So there's a lovely picture there of myself and my colleagues. We set up a working group. So it included physios, 2 lead consultants, quality improvement radiographers and stakeholders from Hywel. We developed a pathway to ensure that there was streamlined working and patients got equal treatment throughout the service. We produced a performer so that we could pass on any relevant information and any specialist input that we did here in Singleton. And we produced a communication channels via Teams so that our communication was much better between the sites. And why? Well, essentially, we wanted to prevent unnecessary admissions to Singleton Hospital, not only for the staff, but also for patients. We didn't want them to be admitted to another hospital away from home. We wanted to improve communication between the 2 hospital sites or the 2 health boards. And we wanted to improve patient outcomes, function and quality of life primarily. We wanted to reduce length of stay and improve patient flow. And we wanted to also ensure that patients were receiving specialist input equally throughout the areas in the service. So here's a diagram of the pathway. As you can see, at the start, the patients are diagnosed with MSCC. They're then transferred to Singleton. They're given a physio and a medic assessment. They're given their radiotherapy and they're transferred back to their local hospital with their handover sheet, which is in the form of the performer. Throughout this time, there's communication via the Microsoft Teams channel to ensure that everyone is up to date with what's going on with the patient. This is our treat and transfer performer. Here we've got all the relevant information that we need for the patient, where the MSCC is, where the location of treatment is, any relevant neurology, any treatment the patient had while they were in Singleton, and any specialist advice that we would give to the general hospital. We also have contact details there, as well as some weaning information. So looking at some financial figures, because everyone likes financial figures. This is based on a £500 bed stay that per day finance has given me. So in 2010, when I first started, the average length of stay for a metastatic spinal cord compression patient was 19 days. That's the average cost of £9,500 per patient. With 42 patients admitted, that's a cost of £399,000 to the trust. Now with this, we're looking at functional outcome as well. Only 20% of these patients left hospital mobile, and that's based on a Tometer scale of function and neurology. In 2019 then, just before the SCORE trial, an average length of stay was 13 days with a cost of £6,500 per patient. 76 patients were admitted, that's a cost per year of £494,000 to the trust, and 63% of these patients left hospital mobile. Now in 2021 so far, with our treat and transfer service, 101 patients have been seen. Length of stay is 0.3 days with a cost of only £150, and greater than 80% of these patients are leaving hospital mobile. So looking further at the outcomes, obviously at the centre of this is that the patient, the quality of life to these patients has improved no end. This is not only with functional outcomes, but also psychological outcomes. They're not having to be away from home so much, they're being rehabilitated much sooner, and the side effects from treatment and prolonged bed rest are much less. Same to their family and carers, the psychological element is huge to a service. There's less pressure and stress to the specialist areas, but also to the non-specialist areas, because they have the relevant information to rehabilitate these patients appropriately. And also then to an organisational level, we've got improved patient flow and obviously a financial cost saving. Future plans then, I've successfully been appointed for the committee for a committee position on the NICE guidelines, and they'll be published in 2023. There's an electronic performer that we've produced on Welsh Clinical Portal, and we're hoping to push that forward now so that everyone can see that electronically. And we're looking at a pathway for discharge straight home with a community service, and this will be for patients who have no neurology, who are ambulatory. We're also looking at a 7-day working service so that you've got therapy input throughout the 7 days. So to conclude, patients successfully and safely treated with a single fraction of radiotherapy in a treat and transfer manner from all areas within the South West Wales Cancer Centre, and specialist physio input and appropriate rehab management and discharge advice has been given for all of the patients. There's been equality within the service for metastatic spinal cord compression patients, and the results have been beneficial not to only the patient, but to the staff, the service and the organisation. Thank you. And if you've got any questions, please don't hesitate to contact me. There are my contact details. And that's the SCORE trial reference if anyone wants to have a little further look. Thank you.
Hello, my name's Diane Webb and I'm with my colleague Nicola May, and we're 2 of 3 occupational therapists that work with our rheumatology department with Aneurin Bevan University Health Board, covering the whole of Gwent. We're going to briefly talk to you about how we've used the Sarah Hand Exercise Programme during the COVID-19 epidemic. And Sarah stands for Strengthening and Stretching for Rheumatoid Arthritis of the Hand. So rheumatoid arthritis, or RA for short, is a chronic, unpredictable disorder that can cause persistent pain, joint damage and disability. Joints of the hands and wrists are frequently affected, resulting in reduced hand movement and dexterity, muscle weakness and joint deformities. And this can have a real impact on a person's ability to manage their usual day-to-day activities, including things around work and leisure, and it also impacts on their mental well-being. So when COVID hit, all our clinics were closed and we were redeployed to assist on the COVID wards. Eventually, when our clinics did reopen, these were to be by telephone or virtual appointments only, as our face-to-face clinics were still suspended. The SARA programme pre-COVID was a 12-week progressive hand exercise programme recommended in NICE guidelines for people with hand problems due to rheumatoid arthritis. We had been using this programme for quite a while before COVID had an impact on us. It was developed by a team of research at Oxford University, who then went on to develop the online MySarah programme, which was delivering the same programme content but on an online version, featuring 6 sessions over a 12-week period, where the person could actually monitor their own progress. So what we did, once we'd had a referral for our patients, these were triaged and we would assess them either over the telephone or use an Attend Anywhere. And this would determine whether they would benefit from the SARA hand exercise programme. Once we'd made that decision, we would explain what the programme was and we'd give them the login details of the MySarah so they could actually start an account and begin their exercises. We then posted out the exercise putty and exercise ball and TheraBand that were required in order to do the exercises. At this point, we also completed some initial outcome measures, which we did at the very beginning and then later on when they finished their exercise programme. This is an example of one of the outcome measures that we used. And as I said, the person would circle the section that meant the most to them. This was done at the beginning and at the end of their treatment so that we could actually measure an improvement.
And this is an example of some of the data that we collected. So patients were asked to rate the change in their hands and wrists from 1 completely recovered, much improved, slightly improved, no change, slightly worsened, much worsened, or vastly worsened. And thankfully for us, everybody fitted into the categories of much improved or slightly improved. And we had some really good subjective feedback from people. They had a wide range of goals. Somebody was able to complete a job application by hand. One lady wanted to be able to play golf for longer. Somebody else wanted to bake and decorate a cake. Somebody wanted to play Lego with his grandson, and somebody else wanted to be able to straighten and style their hair. And these were all meaningful goals to the patients and things that they were struggling with. And we were really happy that they were able to achieve them by the end of treatments. We did experience some challenges, and I'm sure many of you will recognise the sort of picture on the left. And this made it harder for us to carry out a virtual assessment, and we felt it wasn't as accurate as it would be if we were doing it face to face. Different patients had different levels of computer literacy, and some didn't have any access to a computer or to a telephone. Overall, we found that participants of the MySarah programme demonstrated improvements in hand function, and it had no negative impact on pain, their drug regimens, or healthcare resources. The programme is low cost to run and provides an adjunct to DMARD and biological drug regimens. Thank you for listening to our presentation. Here are our references and our contact details should you have any questions.
Hello, my name is Helena Goode and I'm a physiotherapist working in Velindre Cancer Centre. Today I'm going to talk to you about the development of the Neuro-Oncology Joint CNS and AHP clinic which I am a member of. This presentation describes the stages of service improvement we went through in order to develop the clinic for all neuro-oncology patients here at Velindre. During the presentation, I'm going to refer to the terms CNS, which is the Clinical Nurse Specialist, and AHPs, which are the Allied Health Professionals. So what did we know? We knew that the NICE guidelines recommended that neuro-oncology patients' needs should be met by a cohesive, multidisciplinary team from diagnosis to end of life. We also knew that the guidelines recognised that the CNS and AHPs are key members of that multidisciplinary team, and that those AHPs should include physios, occupational therapists, speech and language therapists, and dietitians. However, what the guidelines don't tell us is how best we should be working together in order to meet the complex, changing and holistic needs of the patients. So our key points for service development were: are proactive services superior to reactive services in neuro-oncology care? And does working in a cohesive, integrated way actually enhance patient experience and quality of life? This slide captures the phases from our vision to the reality of the clinic. It has always been a long-standing vision to have a designated, cohesive, integrated clinic led by the CNS and AHP team, providing for patients before, during and after their neuro-oncology treatment. Our improvement project started back in July 2018, and over the last 3 years we have had multiple phases of our clinic. This is depicted in the boxes at the bottom of the slide. During this time we have encountered hurdles and barriers, our main one being funding for a designated team. We needed to facilitate each of our professions to be able to attend the clinics, which was challenging when they already had a busy caseload with different priorities and foci. To gain a baseline, we collected robust evidence during all phases of the journey. Our starting point of phase 1 was proactive when a screening tool was used which highlighted huge unmet needs. During phase 2 and 4, the service was reactive, with referrals coming directly from the wider team. During phase 3, a proactive stance was taken by occupational therapy, speech and language therapy, and the CNS. Phase 5 saw us developing the model to provide integrated, proactive care with all AHPs and CNS through the patient pathway. This required a level of commitment from each individual service and was only possible with the support from our heads of service and the funding that was gained from the Welsh Assembly Government. This graph highlights the peaks and the lulls of the referral rates during each phase of the project. Each line here represents individual service referral rates for this cohort of patients. It demonstrates how during the proactive phases, that's phase 1 and 3, referral rates were higher, and this is particularly evident with occupational therapy and speech and language therapy, where referral rates dropped during the reactive phase. In comparison, dietetics and physiotherapy referrals remained low until we were able to gain funding for these to attend the joint clinic in phase 5. I should highlight that the data for the CNS is not included in this graph, as they have always maintained active involvement with this patient group. Phase 5, which represents the gold standard of care, demonstrates the highest level of referrals across all professions. Questionnaires and semi-structured interviews were utilised at key points throughout the process to capture our qualitative data. Patient feedback, which is a key indicator of service provision, is illustrated here in red, towards the top of the slides. You can see how the comments clearly reflect that the proactive service positively impacts on patient experience. Staff perceptions, represented here in green, also highlighted the improvement our fellow clinicians have observed during phase 5. So what trends and patterns did we find? Phase 1 was classed as proactive, as we identify needs, but patients still had to wait to be seen, and some needs were identified but weren't able to be met at all. So is this really a proactive service? Furthermore, phase 3 didn't include dietetics or physiotherapy, and this led to fragmentation within the service. Phase 2 and 4 highlighted that reactive services resulted in unmet needs of the patients and compromised holistic care. We also found that if the clinic wasn't in place, then often needs went unidentified. The patients are therefore much more likely to end up at crisis point. Phase 5 gained funding through the longitudinal journey, ongoing data collection, and service evaluation, and we're proud to say we achieved Phase 5 during the COVID pandemic, when other supportive services were being suspended. Through being a part of the joint clinic, we as therapists have also had an opportunity to develop our own learning skills and knowledge. We have been able to learn more about what each of our professions can offer the neuro-oncology patient at early intervention, and have been able to identify developments that we can make to our services in the future. We have found the gold standard care is to deliver a joint AHP and CNS clinic with all of us in the same room, seeing the patient at the same time together. And that's what we want to continue to do. We want to deliver a joint, cohesive, coordinated approach, and we think having the clinic integrated into the patient pathway is the optimal way to achieve this. So to conclude, there were many elements that needed to come together to make this a successful service. Some of these were patient engagement. Our patients were the key driver, and their voice during the process helped with the success. Data collection and service evaluation. We needed to show gaps in the service and evidence the need for change. The ability to be pioneering and persevering. Phase 3 was done without any extra funding, and we had to drive to promote the service. And finally, a shared vision, not only in our clinic, but with the wider neuro-oncology team and with support from the Trust. Thank you very much for listening to our presentation. Here are our references.
Hi everyone, so I'm Bevan, a research assistant at Tech Cymru, and we've been involved in the rollout of video consultations over the last sort of 18 months or so, and today obviously we're here to talk about specific speech and language findings with you.
My name is Kath Bowen. I'm professional lead for early years and community children's clinics for speech and language therapy in Aneurin Bevan Health Board, but representing our whole department in terms of paediatrics and adults as part of this presentation.
So Tech were involved in the rollout of video consultations over the last 18 months or so. This was on a national level, so it went out to all services within Wales. We've had a really positive response from all services. We use a 4-phased approach to do this. We look at where it's working, for who, and what we can do to improve on that really. We've had lots of consultations over these last 18 months, and patients do rate them really highly, as you can see, 92.4% of the time. 90% of these patients as well do want to keep using VC, whether that's blended or just purely VC as well, so that's important to note going forward. Specific VC SLT findings, this is the quality of the video calls. So when patients were asked this and clinicians, overall 73.3% found that their call was excellent, very good or good. Patients do rate their calls slightly higher than clinicians, but overall that is a really positive response. Benefits and challenges as well from both patients and clinicians within speech and language therapy here. So patient along the top and clinician along the bottom. The most relevant challenge for patients really is the preference for face-to-face or telephone consultations. The least relevant is access to a safe space. So it's really nice that patients do have that access for the most part at home to have these consultations. Clinicians, they do have more relevant challenges than patients. There are a couple of issues with the audio and video at times, which obviously does impact the consultation, which is something to be aware of really when taking this forward in the future. But for benefits, the patients found a massive benefit in the reduction of infection rates. This could be COVID and normal hospital infection rates too, and a massive impact as well on their parking, travel and the environment, which was a huge benefits for patients, which lots recorded. Not as many benefits for clinicians, but they did think that the lowered infection rates was really important going through these last 18 months, which is really important to bear in mind. Patient future use of VC as well has been captured, which is really nice to look at. 984 patients were asked and 92% of them said that they would like to use VC in the future, and only 0.3% said that they wouldn't use it again. Obviously, it's important to note that this has been a very uncertain time. VC was rolled out 18 months ago now, so it's important to look at a blended choice going forward and that patient preference, which Kath will talk about now.
So as part of speech and language therapy in Aneurin Bevan, just over the last 6 or 7 months, we've looked at how our sort of mode of appointment has changed. So obviously during the pandemic, we were just thrilled to have a platform like Attend Anywhere so that we could keep our service going. We never closed. We were always open for business during the pandemic, which was great. But I suppose as society is opening up again, expectations that face-to-face should and will be available is increasing, rightly so. And I think we're probably up to about 45% face-to-face across our whole department now. Interestingly, in our adult team, they are still predominantly using or mostly all virtual appointments for their outpatients, but in paediatrics, probably unsurprisingly, maybe we want hands on the child a little bit more, we are doing more face-to-face. So thinking about the positives, I won't reiterate what Bevan has already said because there's lots of similarities here when we were reflecting on this as a staff group. But the main ones for us, I suppose, was that in terms of a communication environment for the service user, whether that's the child with a communication difficulty or an adult with a communication difficulty, they're absolutely in their own familiar environment, whether that's home, school, nursing home. And we can really see their communication sort of strengths and difficulties in that setting, which is great for us rather than in a sort of artificial clinical environment. For us, it's much easier to work with the agent of change, which is basically just a posh word for saying who are we actually working with to try and achieve some positive outcomes for this service user. So often when it's the child with a communication difficulty, we're not always necessarily working directly with the child or just directly with the child. That we might be working through with parent, carer, maybe somebody in school. And again, maybe for an adult with a communication difficulty, we'd be working through their family or maybe somebody looking after them in a nursing home, residential home. So it's been much easier for us to, I suppose, convey that message that actually the person that we want to work with isn't necessarily the person with the communication difficulty, because we're the other side of the screen. So that's been great. A lot of the other positives are similar to what Bevan has spoken about already. The main thing, I suppose, for us, again, then, is that because we just need a chair, a desk, and a laptop to use Attend Anywhere, less clinical space is required. So we need less rooms in a hospital or a clinic. We can maybe work from home. We can maybe work from a pod, so that it sort of means that there's going to be more clinical activity happening within the same space, theoretically, which is great. And the flip side of that as well then is because we can't only book our sits and clinic room on a Thursday morning for our face-to-face appointments, we can be doing Attend Anywhere appointments throughout the week. It just maybe means that there's more options for service users in terms of maybe picking what day is better for them than others, that sort of thing. And importantly, and maybe this was something that we were worried about maybe at the beginning of the pandemic, feedback from staff is that they can absolutely still build rapport with service users through the screen, which is great. So if everybody's happy, everybody's engaged, we're still achieving the same or better outcomes, then yeah, absolutely makes sense to continue virtually. But it doesn't work for everybody all the time. So I think, like Bevan said, patient choice for us is key now. And if for whatever reason the therapeutic relationship and the rapport has broken down over virtual appointments, then absolutely, we're encouraging staff to reconsider face-to-face appointments, or at least think about that blended approach again. Formal speech and language therapy assessments can be challenging just because of the nature of what we do. It's communication at the end of the day. That's not that easy to always assess over a screen. Digital poverty, the impact of that obviously is huge, and English as an additional language, maybe trying to avoid that as another barrier if we're doing virtual appointments. Screen fatigue, maybe families, service users, and absolutely staff are really keen just to see people again, a bit of human contact, and then that's going to be key, I suppose, in terms of job satisfaction as well. And for us, we do have better attendance at the moment for face-to-face appointments, and whether or not that's just the sort of the novelty factor again of that being available, that might not necessarily continue, but it does feel as though people are really valuing those face-to-face appointments. So I suppose when there are so many variables for us, people don't fit into neat boxes, obviously. It's about how we're advising staff what approach to take. And we're thinking about some research projects to help guide us in that evidence base. So just on the screen, there's 3 examples of projects that we've got going at the moment. So if anybody wanted any further information, you know, rather than me reading it through, feel free to get in touch. So I suppose in summary, our ultimate aim as a department, so through gathering and listening to feedback from service users and measuring impact on outcomes, to develop that blended offer of virtual and face-to-face service delivery methods, following the principles of person-centred, prudent and value-based healthcare, to ultimately do the most good, least harm for the most number of people. So thank you.
Thank you.